all so much for coming. We're excited to be in conversation with you about services for families and innovations in services for families. I'll introduce myself, and then I'll invite my co-presenters to introduce themselves, and then we'll hop in. So my name is Bobek, and I'm a clinical social worker at the Partnership to End Addiction. We're based out of New York City. I also work as a family therapist and am deeply invested in making services for families more appropriate, more attuned, more accessible.
Thanks, Molly. Hi, everyone. I'm Alex MacLean. I work.
Oh, Alex, I can't.
Oh, sorry. Can you not hear?
That was my end. Sorry.
Okay. I have a background in clinical psychology, and I work here at Partnership with Molly and Marcus, who is also on this call. And I'm involved in a couple different things, but mainly training coordinator, working on a few different projects related to family engagement in adolescent substance use treatment.
Hi, and good afternoon, everyone. My name is Marcus Daugherty, and I work with Alex and Molly here at Partnership to End Addiction. And just by a little bit about me, my background is in mental health, licensed mental health counselor, also in private practice as well. And my main role at Partnership is to really provide training and technical assistance to SUD providers in the state, as well as to assist in other initiatives and other family service training initiatives such as this one. So I'm glad to be here, and I just want to say welcome and thank you.
So we're each going to share a little bit about some of the work that we have done and are doing at Partnership. One thing I'll say as we're getting going is that all three of us will share some slides, some information that we're going to be in conversation with you all about. And a lot of the work that we're going to talk about is relational work, supporting providers and working more relationally. And we're all in relationship together for this hour together today. So we're going to make sure that we have time at the end of our presentations for comments and questions, but we also want to be really explicit about an invitation for comments and questions and introductions. Thanks, Bonnie, for introducing yourself in the chat as we go. And so am eager to hear from you all as we talk, and then again when we have some dedicated time for that at the end. So I will share my screen for us to start. All right, so here we go. Let me actually just do this because I want to make sure I can still see the chat. Maybe I'll do this, and then that will make it possible for me to see the chat and folks' videos despite wanting to make it full screen here. All right, so we'll try that. So I'm going to talk a little bit today about a project that began and continues at Partnership to End Addiction. We began this project, the origins of this project, started thinking about this project 14 or 15 years ago, and it continues as it evolves. And so I'm eager to share with you a little bit about its history and then where we are now. And the topic of the time that I'm going to spend talking with you all together today is thinking about this premise of core elements of family therapy for adolescent substance use. And we think about ourselves as making disruptions that are innovative. Sometimes that's a little bit of grandiosity that we allow ourselves in thinking about the work that we do. But if you'll allow it, then I'll lean into that for the conversation today. So one of the key things that we want to share at the beginning of this conversation is making it explicit that family therapy is an evidence-based approach for adolescent substance use and related behavior problems. When we're talking about adolescent behavior problems, we're thinking about conduct problems and delinquency, oppositionality. We're of course talking about substance misuse and abuse. And when we're thinking about what family therapy is, now that we're understanding it to be an evidence-based approach, we're thinking about it as an approach for providers to intervene directly in family relationships, rather than leaning into the idea that just the young person or the adolescent that is struggling being the site of intervention. We're thinking about working systemically, working with relationships, and inviting change in relationships as the key mechanism for change for the individual young person. In addition to intervening directly in family relationships, family therapy addresses key extrafamilial systems as well, thinking ecologically. When we're talking about working systemically, we're talking about working within a family, and we're also talking about between families and larger systems, including systems of oppression, including the different ecologies that young people and their families are involved in, whether that be school, whether that be their neighborhoods, whether that be their communities, their faith-based communities, their spiritual life. How are we thinking about all the different systems that families are involved in? And when we're thinking about this evidence-based approach, what we're looking at for the most part, although we'll talk about that in a moment, is looking at manualized family therapy that represents a profound success story. And that when it's compared to other evidence-based approaches for adolescent substance use and behavior problems, say cognitive behavioral therapy, for example, it wins or ties every single other approach. And so the evidence is quite clear about how effective family therapy is for adolescent substance use and behavior problems. And when we're talking about these manualized family therapies, we're talking about some significant brand names, manualized family therapies that are proprietary, have specific approaches, and have had a lot of success in research studies and in helping families and helping providers work with families. And those brand names are brief strategic family therapy, functional family therapy, multidimensional family therapy, and multisystemic therapy. When we're talking about manuals and manualized family therapy, we understand that for disseminated implementation purposes, actually getting this approach in the hands of providers and in the therapy rooms or Zoom therapy rooms with them and adolescents and their caregivers, we understand that there are some significant barriers for implementation, some significant barriers for dissemination. The first is clinical complexity. These manuals can be quite complicated, with lots of different components, with interventions that are sequenced and need to be sequenced in a particular kind of way. One thing needs to happen before another. Different family members need to be present in different constellations in order for the treatment to be provided in the way that it was intended. And that can be quite complicated. And so that's one feature of these manuals that has all this success. Another feature of these manuals is that in order for them to actually be effective, there needs to be a lot of training and a lot of quality assurance. And we know that training and quality assurance is quite expensive. We know that there's a lot of turnover in programs that treat youth and families. That creates more of a burden for training. Training is expensive, quality assurance procedures are expensive and quite demanding and doesn't necessarily really end, right? This is an ongoing processes that folks that are using these manuals need to utilize. And the last barrier that I'll name is thinking about fidelity maintenance. One of the things that the research shows us is that when people are using these manualized treatments but not to fidelity, there are diminished outcomes. Things don't go as well. And so the question becomes, if family therapy is effective, but there are these issues with manualized treatments, what then can we do? And that's where this idea of disruptive innovation emerges, and thinking specifically about a core elements approach. And we have some metaphors here. We understand that sometimes when we're banking, you need to go to the bank teller, but a lot of times you can just go to the ATM. When you're needing reading glasses, sometimes you need to go to the optician, and sometimes you can get over-the-counter drugstore eyeglasses. And so when we're thinking about core elements approach, we're thinking about an approach to family therapy that is scalable, sustainable, more affordable, and potentially, hopefully, just as effective as drugstore eyeglasses and the ATM for certain transactions. And so that's the role that Core Elements is meant to play in thinking about disseminated implementation of family therapy. The question, though, in our work in wanting to develop a Core Elements approach for family therapy became like, but does non-manualized family therapy work? Will an ATM version, will a drugstore eyeglass version work? So we had the opportunity 14 or 15 years ago to do a randomized controlled trial where we worked with non-treatment seeking youth and their families in New York City and split them up. We recruited over 200 to participate in treatment. We split them up between different sites, and we divided them between folks getting routine family therapy and then what we call treatment as usual, which is, as we know, treatment as usual is primarily individually oriented, interpsychically oriented at a few different sites in New York City, to see how did it go. Was routine family therapy at a clinic that was not using a manual, but just had family therapy as its approach. How did it go? How do we compare between these two for these non-treatment seeking youth and for family therapy that was not manualized, but just the sort of beating heart of this clinic, and every case is a family case at this clinic. And we were really pleased with the findings. One thing that is good news for all of us, no matter where people that we care about are in treatment, is that both routine family therapy and treatment as usual were effective. They both work. The youth that enrolled in treatment in both places, at all different places, had improved outcomes. Routine family therapy exceeded treatment as usual effects on 5 out of the 12 outcomes we measured. The other findings that was very interesting is that the outcome benchmarks were comparable to those outcomes that we see when providers were using manualized family therapy approaches. So non-manualized and manualized family therapy in this particular study had the same kind of impact. And then when we're talking about adherence and fidelity, the therapists that were working with a family therapy approach and non-manualized family therapy approach in this study surpassed adherence than what we find in manualized ecological family therapy approaches. And so this study was really good news for us in saying family therapy in the real world can work. Family therapy without a manual can work. Then the question became for us, so how do we help folks understand what routine family therapy could be? How do we understand what is working in these manuals? And how do we offer an approach that is attuned to this idea of core elements, that's in line with this idea of core elements? So we spent some time looking at videotapes from the 3 most prominent models of manualized family therapy for adolescent substance use and behavior problems. And those 3 prominent models that we spent a lot of time looking at videos for were multidimensional family therapy, brief strategic family therapy, and functional family therapy. My assumption is that folks here have had some exposure or heard of one or more of those models. What we did was take 100 videotapes from each of those models and watch them and rate them using the fidelity scales from all 3 of the models. So we took a MDFT tape and watched that with both the MDFT scale, how much MDFT was happening in this session, and then also with the brief strategic family therapy scale and the functional family therapy scale, and to see what is actually core, what's common across these different models. And we're looking at these tapes that were gold standard tapes, that we knew that what was happening in these tapes was adherent to the models that they came from. Were they also coming up in the models that they didn't come from? And sort of cross-referencing fidelity scales with gold standard tapes to see what's core and what's common across these 3 models. And we wanted to see, could we distill some common factors? Could something come up that represented what is essential for adolescent family therapy across manualized effective approaches? And to our surprise, items hung together. Factors emerged across these 3 different manuals. And those factors were interactional change, a therapist, inviting people to relate to one another differently in session, relational reframe, what I often think of as the fundamental technique when we're wanting to take an individual youth problem and transform it into a relational problem with relational solutions. Thinking about adolescent engagement, these three different models of family therapy, and then relational emphasis, focusing on relationships again as the unit of change. And so we understood that these common factors hung together in gold standard tapes that emerged from research studies with a lot of supervision and a lot of support for these therapists working hard to be adherent to the family therapy approach. But what about if we're looking again in the real world setting? So we took these items, these techniques that were core and common across the 3 manualized family therapies and applied them. We have a new scale, the core elements of family therapy scale, and we applied them to routine family therapy sessions that were happening in the real world or research settings in which they were not the gold standard. And to see, now this scale that is common, the scale that represents core, that represents fundamental family therapy techniques, does it have legs in the real world? Could we take these distilled common elements and come up with confirmed common factors for routine family therapy? And again, to our great surprise and excitement, we experienced success and yielded, with some differences, some things that shifted, a set of items that we can conceptualize as the core elements of family therapy. We have some listed here, not some, all, they're listed here, according to their factors that they emerged from, and again, thinking about what the manuals that they emerged from originally. And so we spent a lot of time watching a lot of videotapes, poring over different fidelity manuals, thinking as critically as possible about what these manuals had in common, what's different between them, what actually is the thing that moves the needle and making change for individual youth and in change for individual families and families embedded in larger systems. And these are the items that yielded from that process. Again, thinking about change in behavior, thinking about emphasizing relationships, thinking about how to reframe something relationally. And then this adolescent engagement factor was really interesting in terms of how it helped us understand when you're engaging a youth in family therapy, it's a much different practice than engaging a youth in individual therapy. And so we learned a lot about what's core and what's common, and it created an opportunity for us to think more creatively and carefully about training opportunities and different ways to disseminate and implement, now that we're not talking about manuals anymore, but core elements. And that's where Alex will come in and talk a little bit about this next phase of this core elements work.
Thanks, Molly. Okay. So, like Molly said, this next chunk of time will just be me going over what we call Family Frame, which is an online training that we have created using the core elements of family therapy that Molly just spoke about as the foundation. So in addition to the hours and hours spent coming up with these original core elements, we have also had the opportunity here at Partnership to engage in 2 research studies where we have been interested in testing out an innovative online training system geared towards therapists that are working in community mental health settings with youth. And so our goals include broadly improving the quality of treatment services for these youth who are struggling with substance use and other behavior problems, and also offering accessible training in these evidence-based practices. Like Molly said, why family therapy? Because it has the strongest research base for treating youth substance use, and we took that opportunity to create Family Frame as a remote and scalable and sustainable clinician training method that promotes family therapy delivery. Yeah, and like we've already talked about, the foundation of this online training system are these core elements of family therapy. So the techniques. So the training system includes a total of 16 techniques, 13 of which are family therapy techniques and 3 are motivational interventions. And the hope in drawing attention to these techniques items is to allow clinicians to become a little bit more attuned to the work they're doing related to family engagement, as well as pulling on some of the more common therapeutic techniques that one would typically use when working with youth. So the family therapy techniques are organized within 5 clusters. So they're a little bit different appearing here than what Molly showed. Just over time, things have changed a little bit, but we have emphasizing relationships, including relational focus and focus on process, engaging parents or caregivers. We have parent collaboration, love and commitment, and parent ecosystem. We have engaging adolescents, the item adolescent goal collaboration. Inviting change in meaning includes reframe, relational reframe, and family focused rationale. And then inviting change in family behavior. So that focuses on assimilating and stimulating dialogue, coaching and processing, and teaching family skills. And then these 3 motivational interventions are kind of what we call like the bread and butter of a lot of therapist work. So joining with adolescents, motivation to change, and affirm self-efficacy. So the learning management system is an online video-based LMS structured in weekly modules that we offer with varying levels of engagement. So I'll talk through each level. So level 1 is, we call it Learn, and that just includes some brief didactic information where therapists are reminded of 3 out of the 16 techniques, just brief descriptions. And then they're invited to watch a 5 to 8 minute video vignette. And these vignettes have been created with real therapists, real family therapists. And then the family members are actors and they're reenacting real life sessions. And we have a library of 50 video vignettes, and they each feature a diverse set of families and therapists and presenting problems. And so we are actually quickly just going to get to watch one of these. So I'm going to share my sound, and just give me a thumbs up if everyone can hear.
Something that's come up a lot today was talking about a time before this difficult period. Mary, can you share a memory that you have of Adrian as a little boy?
Yeah, he was so lovable and so kind and so tough and feisty. He stood up to his older cousins when he was like 3 years old, when they would like tease him or give him a hard time. And he would say, no, 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 bad boys.
Adrian, do you remember that? How do you feel hearing that?
I don't remember being so tough and standing up for myself.
Mom, can you share how Adrian showed he was lovable and kind?
Yeah. He loved to hug and to be hugged. In preschool, he would hug all the kids in the morning. And when he was absent, the other kids would be so happy to see him when he came back.
Mary, when do you feel most connected to Adrian?
I feel connected to him all the time. Well, except recently. I haven't felt connected to him recently, but I think about him all the time. I really loved when he would come into my bedroom and we would sit on my bed and just talk about anything and everything. Like, I really loved that.
Why do you love that?
I love hearing his voice. I love hearing his feelings, hearing his thoughts on things. I really miss that.
You really miss that?
Yeah. We haven't done that in a while. It stopped after he told me his secret.
Why did it stop?
Well, I guess he stopped coming, or I stopped looking for him to come. I'm not sure. Either way, we didn't look for each other.
Okay. Adrian, I've been talking a lot to your mom right now, and I guess I wanted to check in with you. You know, we were talking a lot about the memories and how she feels most connected to you. How are you feeling about what she's sharing?
I guess I feel surprised. Her thinking about me always felt like pressure, but she's just saying that she's gonna always think about me because I'm her kid.
Hey, Adrian, that's a really great insight. You know, both paying attention to her feelings, but also being aware of yours. That's a really good skill. You know, how about those talks? You know, how did you feel about them?
I guess I liked sitting on her bed with her. We would watch TV together, and we'd also talk a little.
So what happened?
I was really angry for a while after I told her about me being bisexual. We had an open conversation before, so I was hoping it wouldn't go terribly, but it was bad silence.
Was it in her room that it happened?
Yeah, I went to her room and she asked me what was wrong because she always knows when something is wrong. So I finally said, I think I have a crush on a boy at school, and it was dead silence, like no words.
No words at all.
No, dead silence. That's why I don't feel safe with her alone anymore.
Adrian, it sounds like you miss the closeness with your mom, but there's also a large injured and hurt part that can't imagine getting close again.
Yeah.
Mom, what's going on for you?
Yeah, I get it. I get it. Adrian, I want to start us back on the road to having a closer relationship. What can I do to make that happen?
Mom, there isn't like one thing to do.
There must be a start. Cheryl, what can I do?
You know, Mary, I'm hearing you ask Adrian what he needs, and that's great. You know, letting him let you know is a way to reestablish trust and safety. And I have a real hope that both of you will get back to a good place. And I'm wondering what it would be like to just have some unpressured time together, just to laugh and be easy with each other.
Okay, so we'll continue, but that's just an example of one of the vignettes featured in the training system. Okay, moving right along. So level 2 is kind of the next level of commitment that therapists are able to engage with, recognize and judge. So after watching the vignette, there's a 5-item coding activity that focuses on practicing recognition and evaluation of the therapist technique use in the vignette that was just viewed. So on the screen it appears 5 items, and the therapists are asked to code or score on a scale from 0 to 2 the extent to which that item or technique was seen in the vignette. And then after completing that, you get immediate feedback, and this is just an example of one item's feedback here. where it shows you what we call the gold standard score, which is kind of like our team of experts score, showing how much the technique in particular was meant to be just demonstrated in that vignette. And then you'll see here there are some therapist statements that are meant to be evidence for that specific technique. So for this one specifically, coaches and processes, these are statements pulled directly from the vignette that provide evidence for why this item was scored positively. Yeah, and so you would see this for all 5 items, and then evidence for anything that was positively scored. After completing the coding activity, therapists are invited to provide comments, ask questions if anything comes up for them after that activity. And then level 3, feedback. Therapists are invited to submit some data on their own sessions with adolescent youth clients. So there are 2 pieces here. There's the inventory of therapeutic techniques, which is a self-report checklist on their own use of family therapy techniques in a session with a youth client and or their family. And they can elect to receive feedback reports, which are kind of just summaries of the data that they have submitted on themselves, just to provide some sense of what they're saying they're doing, what that actually looks like, an opportunity to reflect on the content that they're including in sessions, in case there's any desire to change that, increase the use of family therapy techniques, see how it differs across clients, maybe it's the same across clients. And so here on the right is just an example of one type of infographic that we provide that just shows for one specific client. Here are some data points that the therapist themselves has shared, that this was the extent to which they used different family therapy techniques summarized as clusters. The other piece of data that clinicians can submit, all in an effort to kind of move the needle, make a change in their own clinical practice, are audio recordings of those same sessions. So clinicians can record sessions and submit them to our team for observational coding. And then last but not least, level 4 includes consultation. So consultation is offered to clinicians and hopefully supervisors as well on a weekly or a bi-weekly basis. Can be done in person or remotely. And the model is meant to be collaborative. It's focused on family therapy improvement goals that the therapist comes up with either themselves or with their supervisor, with a major emphasis on relational dialogue. And some of the core functions that folks might choose to spend time on during consultation are reviewing and discussing vignettes that they have viewed within the weekly training modules, expanded training and content on the family therapy techniques themselves. So kind of just talking about like, what is relational focus? What does that look like? How do I implement it? Our family therapy expert can offer support on particular cases that therapist is working with and struggling with, wanting to increase family therapy techniques with. And then kind of more broadly, just integrating the use of family therapy techniques into their existing practice without kind of like taking it over and replacing all the work that they're already doing, that they've worked so hard to create this practice, the clinical practice, but kind of just adding on to that and moving the needle a little bit, and doing that with individual clients and also with family sessions if that's available. And so that is the end of my presentation. So I'll stop the share and hand it over to Marcus.
Oh, great. Thanks, Alex. I'm just going to share my screen. Okay, let's go to. Okay, just bear with me 1 second here. Okay, slideshow. Okay, so what I'd like to do for the remainder of our time together is talk a little bit about craft as a family intervention, and also as part of a initiative that the New York State Office of Addiction and Support Services, in conjunction with partnership, collaborated on in terms of craft within New York State. And basically, just a quick update. The goal was really to bring more family services interventions within the SUD system in New York State. Given that historically, a lot of the treatment focus was really based on individuals and not so much on families or significant others that were impacted by their loved ones' substance use. So the goal was with CRAFT and OASIS was really to enhance a understanding of family services interventions, and to also introduce CRAFT as a treatment model, a treatment intervention. So just some terminology for you just to be aware of as I go through the presentation today. The ones that are really major to know are just CRAFT, what CRAFT stands for. You'll see FM, family member, CSO, which is concerned significant other, IP, which is identified patient, and engagement was really defined as a loved one entering treatment. The first two acronyms you see refer to community reinforcement approach and adolescent community reinforcement approach. These two approaches were actually the precursors to CRAFT, and CRAFT emerged from these two models, these two approaches. So basically, what is CRAFT? Okay, basically, it's a family intervention that really focuses in on the loved one or the concerned significant other, and this is a approach that is slightly different than the direct treatment approach for individuals impacted by substance use. And really the goal here is to focus on the CSO, because if the CSO is taken care of, or if we focus on the CSO's well-being, then that's going to have an impact not just on the loved one that's impacted by substance use, but also changes the family environment, the family dynamic. And then ultimately, by changing the family dynamic, by focusing in on the CSO, that person can be receptive to entering treatment. So just briefly, the three major goals: decrease the IP substance use, get the IP to enter treatment, and increase the CSO's independence of whether the IP enters treatment. Happiness, independent of whether the IP enters treatment. I tend to focus on the third one when I focus in on families, because it's a pretty important one in my view, given that we know historically that people enter treatment, people leave treatment, the recidivism rate tends to be pretty high. So the CSO very often goes through this pattern with their loved one quite a bit. And it can lead to depression, it can lead to anxiety, it can lead to isolation. It could lead to a significant change in the CSO. So again, one of the goals of CRAFT is that if we focus on the happiness or the well-being of the CSO, that'll change the family dynamic in such a way where the loved one would want to enter treatment. So I just mentioned the third one because I think this is really what I think is the crux of really this family intervention for folks that are impacted by their loved one's substance use. Okay, so how does CRAFT help? Okay, it helps very often by helping CSOs to learn that sometimes their own behaviors may unintentionally promote substance use in their loved one. Okay. And what we try to do in craft is replace those behaviors with new and positive ways to communicate and solve problems. So just a little brief history here. Craft was developed over 40 years ago initially, and it was based on principles of behaviorism, basically positive reinforcement, and the whole context of how if you weaken a behavior, that is less likely to occur. So that was the original thinking behind craft, very, very behavioral. Over the course of time, it also became much more adoptable. So as you may know, historically, we went from behaviorism to CBT to person-centered work. And craft has kind of emerged as those models have also evolved as well. Okay, so why work with families? Okay, we know historically and anecdotally from the research also that treatment tends to be focused more on a person that is that has an SUD, but very often the family member tends to get neglected. Okay, but we also know that the family member is a key part to a person's recovery. They have extensive contact with their loved ones. They know what the behavior patterns are. They have very intimate knowledge, and that knowledge can be used not only for the well-being of the CSO, but to really help the loved one into treatment again. Okay. And then again, early programs like the community reinforcement approach found that family members are crucial collaborators in treatment. Okay, and just again, family members and CSOs also need help very often around their own issues that are secondary to the loved one's substance use. So they may have issues around interpersonal violence. They might have financial issues. There may be marital conflict. There may be a lack of support. So again, if you look at craft in terms of supporting the CSO, if we can help to alleviate or ameliorate some of these issues, that changes the family dynamic, and that may encourage the loved one to get into treatment. Okay. So the question emerges in terms of why should clinicians or counselors employ craft as a family intervention? Number one, it's an approach that's non-judgmental. And we also attempt to avoid confrontation through a use of a conversational, non-directive style. So I had talked a few minutes ago about how craft as an intervention has emerged over the course of time. This is one example where it's used in a very person-centered way, in a non-judgmental way, in a non-confrontational way, where we really want to encourage open communication and dialogue. And it also seeks to understand the viewpoint of individuals and families. So we're not only interested in what the viewpoint is of what's happening with the IP or the loved one that's impacted by substance use, but we're also interested very much in understanding what's happening with the CSO and how we could assist in improving their well-being. So on this slide here, I just gave a brief outline of a counseling format that we developed with Oasis around using craft. So it was really designed based on how providers in the Oasis system do counseling, provide counseling. And if you look at the structure here, we looked at a 12-session model where each session is 1 hour each, typically once a week. And they can continue for the CSO even after their loved ones enter treatment. So what we found is that when the IP does enter treatment, the CSO still very often needs support. So craft doesn't end once the IP enters treatment, okay? And the purpose of the sessions, we always want to empower the CSO to influence change. We want to train the CSO in behavior change, and not only behavior change, but we want to teach skills and coping skills. And the goal of that is really to improve the quality of life for the CSO. And we also want to prepare the CSO and possibly the rest of the family for treatment engagement. So basically, what you'll find here, and we won't have time to go through it today, but there's several interventions or several techniques actually within craft that could be used to help the family member or the CSO make an invitation for the loved one to enter treatment. So on this slide, I just want to highlight a couple of adaptations of craft over the years. So craft could be used in groups. Craft can also be used as a family member or CSO who's already in treatment. Craft has been used with trauma survivors and individuals diagnosed with PTSD, and also individuals with gambling problems as well. And there are also peer-run craft groups as well. I just want to highlight some craft procedures or some craft techniques, communication skills training, problem solving, enhancing the CSO's happiness, and goal setting. The first two in particular are pretty popular and fairly easy to facilitate. So if anyone gets into a deeper dive or gets into a deeper craft training, you'll actually see that these are the two pretty well used and pretty popular techniques within the craft approach. Okay, and enhancing the CSO's happiness, there's actually a happiness scale that we use within craft that kind of gauges where the CSO is at. And then from there, we can develop goals with the CSO to increase happiness and self-esteem and other areas as well. Okay, so just to kind of sum up and conclude, I just want to mention that craft is an approach that's adaptable to meet the needs of individuals and families because it's person-centered, it's person-driven, as opposed to program-driven. It's holistic and it's flexible. And here, just some recent research on craft. And I just want to thank you. And I think I'll stop my share here. And the time that we have left, I'd just like to stop and kind of have a question and answer period if time permits. And then we'll just go from there. So I'll turn it back over to Molly.
Thanks, Marcus. Thanks, Alex. Thanks, everyone, for listening and tuning in to what we had to offer. As Marcus mentioned, we'd be happy to hear any comments, any questions, either taking yourself off of the mute or typing in the chat.
First of all, I want to say thank you. This has been very informative for me as a new Federation of Families chapter providing peer services to our community. You mentioned about craft being able to be used with trauma therapy and folks with PTSD. Are there other applications that it could be used with? Some of the families I serve, their kids are diagnosed with ADHD or oppositional defiance disorder. Could it be adapted for that as well?
That's a good question. What I would say is that craft is adaptable and it is flexible. That could be used in combination with other approaches and other techniques. I would suggest, though, for children with that particular type of diagnosis, you may want to look up some of the earlier research prior to craft, like the community reinforcement approach and the adolescent community reinforcement approach, because those particular approaches were specifically designed for adolescents and for children. So they'll probably have much clearer and much more specific techniques and interventions for that age group. But if you use craft is adoptable. But in terms of working with adolescents and children, I would refer to the CRA approach and the ACRA, just kind of take a look there first.
I really appreciate it. Thank you so much.
Oh, you're welcome.
We also know it's Friday at 5, so there's a part of me that wants us all to maybe go around and say who's got the best weekend plans. And we'll definitely stay on, you know, in case folks have questions. And I hope that everyone is enjoying the conference and continues to enjoy it tomorrow, as I understand it's continuing. And we'll stay on. And but folks, feel free to start your weekend.
The only weekend plans I have are tomorrow's conference meetings and church on Sunday, and the rest of the time I'm going to sit back and just watch some movies.
That sounds great. That sounds really good, Bonnie.
Just one other question. Can we email you guys if we have more questions down the road?
Yeah, of course. We can put our email addresses in the chat.
That would be awesome.
Hi, I'm sorry I'm coming in late.
Oh, hey, Pat.
Hi. What are we doing right now? In a breakout?
We're wrapping up, Pat.
Oh, okay.
Thanks for coming. Yeah, we were just hanging on in case folks had some questions. For myself and Alex and Marcus, we were talking about innovations and working with families for
Okay.
providers from 4 to 5, but we're ending. But if this link might be live for something else, but we're probably gonna hop off now.
Okay, but it's recorded, right? So they're gonna post it?
I'm
Yeah,
assuming, yeah, go ahead, Alex, sorry.
Yeah, they'll be sending out the available recordings, I think maybe in a week or two.
Okay. All right, great, great. All right, well, you all take care. All right, talk to you later.
You too, Pat.
Bye-bye.
Bye.
All right, I think it's time to sign off. Yeah.
Okay.
Have a good weekend, everybody.
You too.
You too.
Bye.